The different diseases or illnesses that you will find in the renal genitourinary system. So first off, an AKI, an acute kidney injury, it usually occurs very quickly, but it can be reversible. So it's the rapid loss of kidney function from renal cell damage. There are 3 different causes of an AKI. They can be caused from pre-renal, intrarenal, or post-renal causes. So pre-renal is outside of the kidney completely. So causes include dehydration, blood loss, decreased blood volume. Intrarenal is intra, so it's within the kidneys. Example of causes are tubular necrosis, intrarenal infection, or even an obstruction. And then post-renal is a cause that occurs between the kidney and the urethral meatus. So examples are bladder cancer or kidney stones. So AKIs have 3 different phases. You have an oliguric phase, a diuretic phase, and a recovery phase. So with your oliguric phase, there is a decrease in urine output. You're going to see less than 400 cc's of output per day. There are signs of excess fluid volume and hypervolemia. So those different signs of excess fluid volume may be hypertension, edema, pleural effusions. The patient in the oliguric phase might have some Kussmaul respirations, which signifies metabolic acidosis. That's that deep labored breathing. They're going to have hyperkalemia, hyponatremia, and hypocalcemia. With the diuretic phase, the urine output rises slowly, followed by diuresis, so a goal of 4 to 5 liters per day. Increased urine output is resultant of the damaged nephrons recovering the ability to excrete waste. So in this diuretic phase, dehydration, hypovolemia, hypotension, and tachycardia may occur. You also may see hypokalemia and hyponatremia. So the electrolytes are diluted. You want to definitely monitor daily weights for this patient. Make sure they have on the same clothing. You're weighing them the same time of day. And then any increase in 0.5 to 1 pounds per day is indicative of fluid retention. Your recovery phase is a slow process. Complete recovery from an AKI can actually take 1 to 2 years. So during that recovery phase, you're going to have an increase in your glomerular filtration rate with a continued decline in your creatinine and your BUN as your kidneys begin to recover. In AKI, it can progress into chronic kidney disease over time. For a patient with a history of an AKI, you want to educate them on the importance of following a renal diet. So it's a low to moderate protein diet. You want to decrease the workload of the kidneys, and then you encourage high carbohydrates. Chronic kidney disease. Chronic kidney disease is very slow and progressive. It's irreversible loss in kidney function. So you can see you have mild, moderate, severe, then end-stage renal disease, and then your differences in the glomerular filtration rate. When there's about 75% function of the nephrons is lost, when about 75% of the nephron function is lost, then the patient will become symptomatic of the chronic kidney disease. When we're thinking about causes for kidney disease, the primary causes are going to be diabetes, hypertension, recurrent kidney infections, and then, like we said previously, chronic kidney disease can follow an AKI. So there are lots of signs and symptoms of chronic kidney disease, as you can see here. So when we're thinking about those signs and symptoms, thinking about the features of chronic kidney disease, I want you to think about the fact that the kidneys are no longer filtering waste products from the blood. So they are unable to conserve or excrete sodium or water. So the patient is going to have symptoms of excess fluid. So this is going to be dyspnea, shortness of breath. They might have crackles in their lungs, pulmonary edema. They're going to have signs of acid-base imbalance because it's going to affect all the major body systems. And then CKD, if it becomes severe in stage, may require dialysis or kidney transplant to maintain life. The patient with chronic kidney disease will often have anemia, which results from decreased excretion of erythropoietin by damaged nephrons. The decreased excretion of erythropoietin is going to result in a decreased production of red blood cells. Treatment for this anemia includes the administration of hematopoietics to produce maturity of the red blood cells. In a patient with chronic kidney disease, they may develop hyperkalemia. So if they do develop hyperkalemia, you definitely want to place them on telemetry due to an increased risk for dysrhythmias. But also if they're inpatient, they may require administration of dextrose and regular insulin, calcium, gluconate IV, and then sodium bicarbonate IV, which can help to bring the potassium levels down. In a patient with CKD, you want to avoid potassium medications, potassium-sparing medications such as hydrochlorothiazide or triamterene. So they also might develop elevated magnesium levels and elevated phosphate levels. Remember, when a patient has elevated magnesium levels, they might have reduced or absent deep tendon reflexes. And then with elevated phosphate levels, they are going to need, they may be given like stool softeners or laxatives because so if they have elevated phosphate levels, they'll be given phosphate binders to help to lower those phosphate levels. Those phosphate binders can cause constipation. So then the patient may be given stool softeners or laxatives to help treat that constipation. In a patient with chronic kidney disease, you want to avoid the administration of aspirin. So aspirin is excreted by the kidneys. If they have kidney disease and you give aspirin, aspirin toxicity could occur. All right, so uremic syndrome is the kidneys are no longer able to excrete waste products, so those waste products build up in the body, causing systemic symptoms. So uremic syndrome is systemic clinical and lab manifestations of severe CKD or end-stage renal disease caused by the accumulation of nitrogenous waste products in the blood. All right, so hemodialysis, it's a process of cleaning the patient's blood. Hemodialysis does the work of the kidneys. So it is defined as intermittent renal replacement therapy. The dialysate bath, the solution used during dialysis, it's composed of water and major electrolytes. In hemodialysis, it does not have to be sterile. So viruses and bacteria, they're too large to pass through the pores of the semi-permeable membrane. So therefore, it does not need to be sterile. And then a patient undergoing hemodialysis, the hemodialysis can drop the blood pressure. So it's important to hold blood pressure medications prior to dialysis. And then you also want to hold medications that can be removed by dialysis, such as multivitamins, antibiotics, and digoxin. So hemodialysis access. So you can get access for hemodialysis via a subclavian or femoral catheters, which are short-term or temporary. And then more permanent access is through internal arteriovenous or AV fistulas, which you'll often see in the upper arms. So the subclavian or femoral catheters are short-term. They're only used until a fistula or graft develops, which can take up to 6 weeks. If a patient has a femoral vein catheter, they should not sit up more than 45 degrees or lean forward. You want to prevent that catheter from occluding or kinking off. So like I said, an AV fistula may take up to 4 to 6 weeks to mature and be ready for use, but it is permanent access. Once you have that, you don't take any blood pressures or lab draws in that extremity because you want to maintain the patency of that fistula. And then during those 4 to 6 weeks, you can promote hand flexing exercises that will ensure graft maturity. One thing to know and be aware of for NCLEX purposes, if you see it, is something called arterial steal syndrome. So arterial steal syndrome, it may develop in a patient with an AV fistula. It occurs when too much blood is diverted to the vein. Therefore, arterial perfusion to the hand is compromised. You always want to monitor for clotting in a patient with an AV fistula, which may be signified by numbness or tingling in the extremity or the inability to palpate a thrill or auscultate a bruit over the fistula. So palpating a thrill, auscultating a bruit will be part of your nursing assessment in a patient with a fistula. If you cannot do these things, it could be evidence of a clot. Patients who receive hemodialysis regularly, they also receive fistulograms or fistula maintenance regularly to keep them patent and open. And also, in a patient receiving hemodialysis, if an air embolism occurs, it is best to place that patient on their left side with their head down in Trendelenburg position, just in case that comes up anywhere. All right, so you have hemodialysis and then you have peritoneal dialysis. So in peritoneal dialysis, a peritoneal dialysis catheter is inserted into the abdomen. That is called a Tinkoff catheter. So that Tinkoff catheter is inserted into the abdomen, and then the peritoneum acts as the dialyzing membrane. So peritoneal dialysis, it works on the principles of osmosis, diffusion, and ultrafiltration. There is a transfer of fluid and solute from the bloodstream through the peritoneum and into the dialysate solution. So the solutes will move from an area of high concentration in the body to an area of lower concentration in the dialyzing fluid. So the dialysate solution, it is sterile. It may have some added heparin or insulin in it, but it is sterile. The higher the glucose concentration, the greater the hypertonicity of the amount of fluid, the greater the hypotonicity and the greater the amount of fluid removed during peritoneal dialysis exchange. So increasing the glucose concentration increases the concentration of active particles that cause osmosis, and thus it increases the rate of filtration and the amount of fluid removed. So one peritoneal dialysis infusion, one exchange, is equal to filling of the space, it dwelling, and then it draining. So the patient is going to fill 1 to 2 liters of dialysate fluid by gravity into the peritoneal cavity. This usually takes about 20 to 30 minutes. Then the fluid will dwell in the peritoneal cavity for anywhere from 30 minutes to 8 hours, depending on the specific prescription. And then they're going to drain that fluid via gravity into a drainage bag. You do not want to allow the dwell time to extend beyond the prescribed amount because there will be an increased risk for hyperglycemia with the elevated glucose concentration in the dialysate solution. All right, so there are 2 different types of peritoneal dialysis. One is continuous, which occurs over a continuous process over 24 hours. There's no machines. And then you have automated peritoneal dialysis, which requires the use of a peritoneal cycling machine. Complications. So infection is the primary concern with peritoneal dialysis. So the sites of infection are either the catheter insertion site or the peritoneum, which would result in peritonitis. So peritonitis, if a patient does develop peritonitis, they're going to have fever. You might see a cloudy outflow of fluid, which can be an early sign of peritonitis. They may have some rebound abdominal tenderness, nausea, vomiting. If peritonitis is suspected, you will obtain a sample from the outflow, and then antibiotics may be added to the dialysate solution for treatment. And then, of course, because the dialysate solution is sterile in peritoneal dialysis, you always want to use a sterile technique when connecting and disconnecting the peritoneal dialysis solution bags. Another complication is abdominal pain. In order to help, you can warm the dialysate prior to administration. So the cold temperature of the dialysate could cause some abdominal pain and discomfort. You can have abnormal outflow characteristics, which can be indicative of complications. So a bloody outflow would point in the direction of vascular complications. A brown outflow would mean there's likely a bowel perforation. A urine-colored outflow would mean there's a urine perforation. And then a cloudy outflow would indicate the peritonitis and signs of infection. With insufficient outflow, the main cause is a full colon. So you want to, in a patient with peritoneal dialysis, you want to promote a high fiber diet to prevent constipation. You want to give them stool softeners. And then if you have insufficient outflow, definitely check the outflow position by turning the patient to a sideline position or ambulating just to try to get things moving. And then, of course, you can have leakage around the catheter site as well. It can usually take up to 2 weeks for the insertion site to be fully closed after that catheter is removed. A kidney transplant. So, kidney transplant. If you receive a kidney transplant, the recipient must take immunosuppressants for life. You should have hemodialysis completed 24 hours prior to the transplant. Urine output may begin immediately if the donor was a living donor. And then post-transplant, that urinary catheter will remain in place for 3 to 5 days. So the most desirable donors for kidney transplants are living relatives that closely match the patient. The old kidney is usually left in place, which is kind of odd if you think about it. However, if the recipient has a history of polycystic kidney disease, those kidneys are usually very large and painful, so they will be removed. For the first 24 hours following a kidney transplant, IV fluid replacement is based on urine output, so that is monitored closely and monitored every hour. It is normal for the urine to be pink and bloody initially, but then it should return to normal within 7 days. If there is ever the presence of any gross hematuria or clots, the doctor needs to be notified. Okay, so renal transplant or graft rejection. So this, except in identical twin donors or recipients, the major post-procedure complication following a renal transplant is graft rejection. So you have hyperacute rejection that occurs within the first 48 hours. Treatment includes the removal of the rejected kidney. You have acute rejection, which occurs within the first week. Treatment, it's potentially reversible with increased immunosuppressive therapy. And then you have chronic rejection, which will occur months to years after the transplant. Treatment is still immunosuppressive medications and then dialysis if necessary. So urethritis is inflammation of the urethra. It's commonly associated with an STI. In males, it's often caused by gonorrhea or chlamydia. They may have a clear to mucopurulent discharge from the head of the penis. And then females may experience lower abdominal discomfort. Other signs and symptoms include dysuria, frequency, urgency, and then difficulty voiding as well. Just a side note, a serious complication of untreated chlamydial infection is sterility. So if there's ever any discharge or any concern for STI, getting tested and treated is definitely important. Urethritis and then ureteritis are going to have the same symptoms: inflammation of the urethra and then inflammation of the ureters. Pyelonephritis is an inflammation of the renal pelvis and parenchyma. It is most commonly caused by E. coli. So with acute pyelonephritis, your typical acute onset symptoms, you're going to have fever, chills, CVA tenderness, dysuria. And then with your chronic pyelonephritis, those are going to be a gradual onset of symptoms. It may lead to an AKI or chronic kidney disease in the future. With pyelonephritis, there will be an inability to conserve sodium, and so your body is going to have poor urine concentrating abilities. Polycystic kidney disease. So polycystic kidney disease is cyst formation and hypertrophy of the kidneys, which will result in chronic kidney disease. It is genetic and often asymptomatic until 30 to 40 years of age. So the cyst formation and hypertrophy of the kidneys leads to cystic rupture, which can lead to infection and the formation of scar tissue and then damaged nephrons. There are 2 types of polycystic kidney disease. There's the infantile and adult. With infantile polycystic disease, it results in death within a few months after birth. And then, of course, adult is not diagnosed until 30 to 40 years of age. Assessment for a patient with polycystic kidney disease. They may have flank pain or abdominal pain that worsens with activity and improves when lying down. They may have palpable enlarged kidneys and recurrent kidney infections. So for these patients, you definitely want to increase sodium and water intake because sodium loss occurs. If a patient with polycystic kidney disease complains of gross hematuria, you need to think of cystic rupture. So gross hematuria is the primary sign of a cystic rupture in patients with polycystic kidney disease. You also want to avoid anti-inflammatories and aspirin due to increased risk for bleeding. And then you want to try to prevent constipation. If a patient with polycystic kidney disease becomes constipated, it can place the pressure within the colon can press on the cyst in the kidneys and cause discomfort and possible rupture. All right, hydronephrosis. Hydronephrosis is distension of the renal pelvis caused by an obstruction in normal urine flow. So the urine gets trapped proximal to the obstruction. Different causes for hydronephrosis includes renal stones, tumors, scar tissue, hypertrophy of the prostate. This patient may have a headache, hypertension, and then colicky or dull flank pain that radiates to the groin. All right, so renal stones or renal calculi. So these are stones that may form anywhere in the urinary tract, most frequently in the kidneys. So you have nephrothalamus or kidney stones, and then the urothalamus or the formation of stones in the ureters. Causes of stones include a diet high in calcium and vitamin D. If you're dehydrated, and taking lots of protein, immobilized or elevated uric acid levels, such as in gout. Remember, in gout, you're at risk for increased kidney stones. These patients are going to present with what is called renal colic. So it's pain that originates in the lower back area and then radiates around to the side. It can radiate to the testicles in the men and the bladder in the women. Or you can have ureteral colic, which radiates towards the genitals and the thighs. They may have very sharp, severe pain or sudden onset signs of a UTI, nausea, vomiting, gross hematuria. Treatment for renal stones, you're going to encourage fluid intake, lots and lots of fluid intake to facilitate passage of the stone. And for a patient with renal stones, you want to strain all the urine for the presence of stones, and then you're going to send stones to the lab for analysis. All right, so if hydration does not work, there are other treatment options. You can have a cystoscopy, a lithotripsy, a partial or total nephrectomy, and then a ureterolithotomy as well. So with a cystoscopy, it is performed for stones that are located in the bladder or the lower ureter. So a catheter is inserted past the stones. It's left in place for 24 hours to allow that trapped urine to drain, and then irrigation is performed to dissolve the stone. With lithotripsy, it's a non-invasive procedure used for breaking up the stones. So ultrasonic waves are delivered to the area of the stone and it disintegrates it. So then smaller stones can be passed through the urine. You, of course, want to encourage increased fluid intake to flush out those remaining stones. With a nephrectomy, it's only performed for extensive kidney damage or extensive renal infection. And then a uterolithotomy is a surgical procedure that is performed if a lithotripsy is unsuccessful. Okay, kidney tumors. So the cause, they can be benign or malignant, unilateral or bilateral, but the cause is usually unknown. The patient is going to present with dull flank pain, maybe a palpable renal mass, and then painless gross hematuria. So surgical treatment is going to include that of a nephrectomy, which is going to be surgical removal of the kidney with or without radiation, just depending on the findings. Post-op from that nephrectomy, you want to monitor for signs of adrenal insufficiency, such as large urinary output followed by hypotension and subsequent oliguria. The goal urine output is always 30 to 50 mLs per hour. All right, so epididymitis is an acute or chronic inflammation of the epididymis that occurs due to an UTI, an STI, or prostatitis. So the male patient is going to experience scrotal or groin pain. They may experience scrotal swelling and then pus or bacteria in the urine. So the infective organism, it travels up the patient's urethra and ejaculatory duct and along the vas deferens until it gets to the epididymis. Treatment for epididymitis includes scrotal elevation. So the elevation will help to relieve pain and facilitate drainage. You want to do intermittent cold compresses as tolerated. And then if they do have a UTI, you're going to use an antibiotic to treat it. And then you want to limit the force of the urine stream as well to avoid that increased pressure. Prostatitis is inflammation of the prostate gland. It can also be acute or chronic. So an assessment, these patients are going to be very acutely ill with fever and chills. They're going to have your typical urinary symptoms, dysuria, frequency, urgency. The prostate is going to be very tender, warm, indurated, and then they may have urethral discharge on palpation of the prostate. So you can have bacterial prostatitis, which is obviously caused by an organism, or you can have abacterial prostatitis, which may occur following a viral illness or a decrease in sexual activity. Treatment is going to be antibiotics and increased fluid intake. All right, BPH, benign prostatic hypertrophy. This is slow enlargement of the prostate gland. That enlargement then compromises the urethra, resulting in a partial or complete obstruction. You primarily see BPH in males greater than 50 years old. Early signs of BPH, you're going to have a diminished size and force of the urinary stream. And then late signs of BPH include post-void dribbling. So assessment, decreased force size of the urinary stream, which is an early sign. You're going to have nocturia, urgency, frequency, hesitancy. And then that post-void dribbling is a late sign. In patients with BPH, you want to avoid medications that cause urinary retention. These are anticholinergics, antihistamines, decongestants, antidepressants. You want to be sure to avoid anything that will cause urinary retention.